afternoon, everybody. I'm assuming people in the room can hear me. I have to apologize for my moderate term voice problem. It's getting a little better, according to Dr. Toomey, but I'll make sure I speak in the microphone. I hope the people can not only hear me, but the people who are on Zoom can see us all. And we have a couple of very important presentations and some very important information that's going to be given in today's meeting. So I'm Jim Curran. I'm the chair of the board of public health. I'm also the acting vice chair and the acting treasurer today, and the acting secretary. I don't think we have a treasurer. So on behalf of Mitch Rodriguez, I'll call the roll. Jim Curran, here. John Hopert. Catherine Cheek.
Present.
Thank you. Cindy Mercer. Dr. Mercer. Dr. Shin.
Present.
Mr. Walker.
Present.
Dr. White. Dr. Valier
Present.
White.
Present.
Thank you. Well, we have a pretty good team on board here today. So now I'll turn it over to our Commissioner of Health, Dr. Toomey.
Thank you very much. I'm leaving my mysterious sunglasses on only because I had some eye surgery done and I look like I have a peanut allergy and ate a lot of peanuts, but I didn't. I'm trying to avoid the feedback. Many of you know that I started out my career.
Excuse me, if you have the presentation on your laptop, please mute your laptops if you're in the room. So we won't receive the feedback. Thank you.
I started out my career in Alaska, working in a very remote area north of the Arctic Circle. And so the story of the Iditarod and bringing vaccines to remote places was very iconic to me because it was such an important part of the Alaskan history. And you all know the story of how that's how the Iditarod race started in memory of and recognition of that work to quell a diphtheria outbreak in 1925 in Alaska. Well, fast forward to 2019 when I came into this position. And much to my surprise, I realized that the Georgia State Patrol was actually playing a role not unlike what had happened in Alaska in those early years. And we were having an outbreak at that time in North Georgia of hepatitis A, or having a hard time getting the IG into those areas. And they helped us with both vaccine and gamma globulin. Shortly after that, we had a measles outbreak in Cobb County. And likewise, they assisted us with getting the necessary vaccine and other medications to quell that outbreak in Cobb County. Also at that time, I realized that if there were an animal bite in rural Georgia, that animal head had to be brought to our state public health laboratory. And so it wasn't just vaccine the Georgia State Patrol were transporting, but also raccoons and mountain lions or whatever happened to be the offending animal causing that potential rabies exposure. And I thought this is just really an incredible asset to public health that the State Patrol is willing and able to assist us in so many ways. Well, never did I dream that a few months later, for me in January 2020, we would begin to see the first cases of COVID worldwide, and then our first cases here in Georgia in March of 2020. And at that point, asked the State Patrol once again to step up And I cannot tell you in how many ways the State Patrol was able to assist us. Everything from transporting really hard to acquire testing materials all over the state. Eventually, at the end of 2020 and into 2021, when we had vaccines, transport of equipment, and many other aspects of our response that they were able to help us with, including security at a time that we were getting actual harassment and hostility at many of our events. Several poor troopers had the misfortune of having to provide security to me for a while. And I just want to say they deserve special recognition for the work they did as well. Because I'm sure it was a daily challenge for them too. And then enter, even as we're moving beyond COVID, we've moved into monkeypox. And because of the way the federal government set up the monkeypox response, the monkeypox vaccine was not brought into the state and was able to be delivered in the same way that our vaccine had been delivered during COVID, but in fact could only come to very few sites, which then had to be transported, particularly to rural Georgia. Once again, the State Patrol was willing and able to help us transport that vaccine where it was needed at a time when we needed it the most. And as you will see later today, I really am very proud of our monkeypox response and what our epi curve looks like, in no small part because of your assistance in transporting vaccine where we need it quickly and to try to stop the spread of this infection. All that being said, as we have recognized in our past board meetings, many of the staff who have done such a tremendous job during this COVID pandemic and beyond, we have thought it was really very important and appropriate to recognize the Georgia State Patrol and all the work that they have done to support us throughout this pandemic, prior to the pandemic, post-pandemic, and their continued support has meant so much to us in our ability to be successful. And so with that, I wanted to call up Colonel Chris Wright, head of the Georgia State Patrol, and Deputy Colonel Billy Hitchens, to recognize them for their tireless support. I want to make sure I got them right. I can't see so good. The tireless support there for public health and for all that they have done to support all of us throughout the state. We cannot begin to thank you enough for what you've done for the health of all Georgians, keeping everyone safe at all times, but even in ways that probably the public has never recognized. And so with that, I just wanted to thank you, Colonel Wright. Thank you, Deputy Colonel Hitchens. And it's just a pleasure to be able to honor you today and to thank you in person for what you've done for us over these several years. So thank you so very much. Thank you. Oh, yeah, say something. Sure. Something nice.
We're very humble by this. Thank you very much, Dr. Toomey. But we're very proud to be a partner with DPH and so many of our other partners in state government as well. And we're just honored to be able to help in keeping the citizens of our state safe and healthy, because a safe and healthy state is prosperous for all of us. And so we're grateful for the partnership, and we're certainly grateful to have helped you and your staff during a very tough time. We had a lot of challenges, not just with public health, but we're just glad we were in a position to be able to do all the work that we were able to do. So thank y'all very much, and thank y'all for honoring us today. And this really is not for us. This is for our people, because our people worked during a very difficult time, and we were just glad to be a small part of it. But thank y'all very much.
Thanks again, Colonels Wright and Hitchens. I'd like to add my thanks to them. And before we introduce Dr. Drensick, I'll give you a couple anecdotes from my very long public health career. First of all, I've known Dr. Toomey for a long time. She's very experienced, but she was not in Alaska in 1925.
I just look like it.
Secondly, I was in Columbus, Ohio, as an assistant health commissioner many, many years ago, and dealt with a rabies outbreak in raccoons. Let me tell you, that is no fun. I saw a raccoon kill 2 Great Danes. If you can imagine that. They're really, really dangerous. So you need the Georgia State Patrol to deal with some of these kind of issues. So thanks again. Now, Dr. Jerry Drensick.
Thank you so much, Dean Curran. Thanks to all of the members of the board, all of you that are attending both in person and virtually. Being in person is great. I really just wanted to reiterate what a great pleasure it is to be here in front of you. I want to take this opportunity to, although we're talking about subject matters that we've had the opportunity to present about over many months, I think we have some really good news, and I hope that we're going in the right direction. But again, let me begin first of all, as I typically do, by saying that infectious diseases for us in public health and for our clinical partners are really ever changing. They're very unpredictable. Every day is a new day. But we can be reassured that by having our strong public health infrastructure and partnerships in both surveillance and epidemiology, that we really will be able to develop the cornerstones of prevention and control by collecting the data that is most important to inform these decisions, these data-driven actions, if you will. And so again, very strongly, these subjects are illustrated by our global COVID and monkeypox outbreak. So let's just give a brief update since the last time we were together, which was a month ago. So here's our snapshot as of today. And what we're seeing now in regards to COVID overall is, again, some very good news in regards to sort of the direction of the number of cases and the number of hospitalizations and deaths. However, we really are also beginning to see some new variants start to gain some ground. It's very early in the game, but I think it warrants us to keep a close watch on them. So let me just go through these bullet points. For the last few months, we have had one of the Omicron subvariants called BA.5 serve as really practically the only variant of concern that we've been dealing with over the past few months. It really comprised, almost all of our SARS-CoV-2 infections. It's starting to recede now. Again, it's dropped down to, somewhere about 76, 77% of all of the infections, which still comprises the vast majority. However, we've now seen a trio of new Omicron variants that are, again, beginning to rise steadily over the last few weeks. And in some of these situations, these variant numbers have actually tripled. So again, we're seeing a BA4 subvariant called BA4.6 that in Georgia comprises now very close to 17% of all of our COVID cases. BF7 now comprises a little over 4%, and BA2 0.75 comprises almost a 1.5% of our cases. And all of these are greatly increased over what they were just a few weeks ago, although certainly are not comprising the majority. Whether they will continue to grow or not, I can't say for certain, but this is very characteristic of what we have seen the SARS-CoV-2 subvariants do over time. Again, as one recedes, others rise up in their place. And most of all, what we are seeing so far in regards to this impact on our surveillance indicators so far is minimal. So far, we're still seeing declines in case numbers, both nationally and in Georgia. Our case numbers here in Georgia have been decreasing by about 20% or so each week over the last 3 to 4 weeks. However, there are some parts of the country that are beginning to experience some increases again in COVID cases, particularly up in the Northeast. And we've seen that scenario before in some of the other previous COVID waves during the pandemic, where the Northeastern part of the country is sort of a harbinger for things that can happen elsewhere. They seem to get hit first. We're also seeing some increases in other countries as well, some of them led by these variants that I talked about, this new trio, if you will. And so far, we haven't seen, sort of a strong impact yet in Georgia, but again, it warrants caution and it warrants us monitoring the situation as well. For us in Georgia and also across the nation, our severe outcomes of COVID are also decreasing. Their hospitalizations and deaths are both declining at an average or so, if you look at the whole month, about 20%. And we're so far in Georgia, about where we are as of last week, we're seeing about 100 deaths a week in Georgia. And so that's been pretty consistently down as well. It's still, again, still shows you the severe impact that COVID can have, 100 deaths a week. However, it is decreasing over time. So with new variants rising, certainly our caution, prevention strategies always remain prudent, including ongoing vaccination and the new bivalent boosters that are available as well. So next slide, please. So now let's just take a quick, a little bit in-depth visual dive into what I've been talking about in regards to our surveillance indicators. We'll look at cases, deaths, and hospitalizations here in Georgia. So as you can see on the slide, if you look at the epi curve over time, we are again in the 6th wave of this pandemic. But if you look at the red arrow, over the last few weeks, we've really been seeing a significant decline in case numbers. We've had about an 80% decline in the number of cases of COVID since mid-August. So within a period of 2 months, from 2 months ago to where we are now, you can really see that dip that's really going down, in an accelerated way. Over the last month or two that I had the opportunity to show you this epi curve, it was a little bit slower. It was a little bit more of a plateau, and it hadn't really come all the way down into the valley that we saw in early spring, such as April there. But we're pretty close to that now. So that's good news, and we'll have to continue to keep our eye on these case numbers to see if the rising subvariants make a difference over time. So that's cases. Let's look at the next slide. Here are our COVID-19 hospitalizations in Georgia. As you can see, the epi curve shares the same shape of case numbers really over these 6 waves. And here we are looking very similarly in regards to hospitalizations. Our hospitalization numbers have also come down almost 40% within the last month, and almost 90% since we saw the Omicron peak in the beginning of 2022. So our hospitalization numbers are declining as well, which is very good to see, and is also an ongoing testament to the impact, the positive impact vaccination and boostering. Next slide, please. I wanted to show you two different epi curves in regards to our COVID deaths. We are just showing it in two different ways. The one on the left is really by the date of report, meaning the date that the death is reported to us. And the one on the right shows you by the date of patient death due to COVID. So you see a real difference in these curves, as you can see. When we're looking at date of report, sometimes deaths have an inherent delay in being reported to us because of inherent delays in death certificates and the time that they get reported to us. So as you can see, if you look at the far right of the graph on the left, you know, the curve isn't dropping, you know, as steeply as it is on the right when we're talking about the actual date that the patient died. What this means for us is that, you know, when we're talking about death reporting, you know, there's a little bit of up and down. It's you know, again, what's important to look at over time are these patterns where we are seeing by the time that the individual patient has actually died, you know, we're seeing a drop here in a decline in deaths as well. You know, again, I don't want to minimize this because again, we're still talking about 100 deaths or so a week in Georgia. And if we're looking at the broader picture of the nation as a whole, we're talking about close to 400 people in the whole country that die, not in a week, but every day. So again, good news, but certainly not a time for complacency. Next slide, please. Just to show you again, my point about how hospitalizations and deaths, since they're on the decline, that being due to in part, the positive impact of vaccination and boostering, I wanted to show you these two graphs. And essentially what we're showing are hospitalizations on the left, and we're showing COVID-related deaths on the right. And essentially, if you look at the black line, the tall lines, over the entire period of the pandemic, but if you even want to just stick to, again, the far right side, the black lines represent individuals that are not vaccinated or are under vaccinated. So they're more likely to end up in the hospital or to die of COVID. So those are the highest levels that we are seeing. The red lines indicate individuals that have had vaccination, but only the primary series only, that first 2 doses early on. It makes a big difference. It's certainly reducing it. But again, look at what the booster does. That bottom gray line, you can hardly even see it. It really brings the number of hospitalizations and deaths down to a minimal level. And again, so it really shows us how important keeping up to date on vaccination is. And I hope to see that even to go even down even lower, you know, once we see a stronger impact and uptake of the bivalent booster as well. Next slide, please. So in summary, although we have great news about COVID and we're looking in the right direction, we're really not completely out of the woods yet. Again, the pandemic is not over. We've seen this scenario many times before. And although, again, we have a strong degree of immunity around us, both from natural infections and the availability of boosters and now the new bivalent booster as well, we still have some concerns. We can't be complacent. SARS-CoV-2 as a virus has proven very adept at changing over time, so that as soon as we get down into that case level valley, we get a rise again in, at least we have in the past, of other variants, new variants that may be able to evade immunity and increases in cases. I can't say for certain that that will happen or when it's going to happen, but we need to remain cautious. There's still a tremendous impact of COVID in this country. Like I said before, 400 people still dying every single day. So we can and should expect new variants and new waves. They may never, ever, and I hope they never get, again, as tall or as high or with as much impact as our Omicron waves. But we can expect new variants to emerge. Other concerns at this time, individuals that have just had, again, either a primary series of vaccination or a natural infection are subject to immunity that's waned now. period of 4 or more months is when immunity starts to wane. So if individuals have not been boosted, again, they may be more susceptible to some of these new variants. That's a context. The immune wall may not be as high as it was even a few months ago because in general, we're getting some waning immunity. Too few adults are getting the bivalent booster, or even those over the age of 12 that are eligible. Too few kids are getting vaccinated. And, data and literature are coming out every day about the impact of long COVID. It is real. It is significant. And again, I think from my perspective, it warrants caution as far as why COVID is still extremely important to prevent as much as we can. So in general, vaccination, our boosters, antivirals being prescribed appropriately, especially to those that perhaps are in elderly or more at risk of severe outcomes like hospitalizations and deaths, remain critical as we face new variants and perhaps new surges as we move forward, not only perhaps this fall and winter, but in the years to come. All right, next slide. So I want to shift gears from COVID and talk a little bit about our monkeypox response and about the global outbreak. The news is very good here as well. And I'll always have some caveats to good news, but in this one, I think we're again in so far so good in regards to some good shape. So let's talk about the epidemiology of the monkeypox outbreak and look at the patterns that we've been seeing over the last few months. And again, we continue to have strong surveillance in place so that we can learn about these patterns so that they can inform and target our control measures. So if you look at globally, all around the world, there are just a little over 100 countries that have experienced monkeypox cases in this outbreak. And these are countries that, again, were countries that didn't experience it in an endemic way or naturally, like in West Africa or in Central Africa. So we've been about 70,000 monkeypox cases since May. I mean, that's huge, in regards to an outbreak and how quickly, again, it has grown. And we've had, about 40% of those cases or close to it here in the U.S. alone. About 27,000 have occurred here in the U.S. in all states. We have a little over 1,800 monkeypox cases that have been diagnosed in Georgia. In 64 of our 159 counties. So not in all of our counties, mostly in the metro Atlanta area. About 85% of our cases have been in the broad metro area, but we have seen cases all around the state as well, kind of in many counties, both rural and urban. Our case rates over the last few weeks, both nationally and in Georgia, have been consistently slowing. And as Dr. Toomey alluded to in her opening remarks about the epicurve, I'd like to show you the next slide. And you can really see how we in Georgia, again, the blue lines represent, the blue bars represent, sort of the daily number of cases. And the darker blue line represents the average over the week. So as you can see, we really, peaked in July. And again, have pretty consistently and steeply dropped off in the number of cases over time. And again, as we have been looking over the last few months, this has been a consistent decline, really down to, we were documenting in the peak days, maybe 60, 70 cases a day here in Georgia. And we've been down to anywhere from 1 to 6 to 7 or so per day, over the last week or even the last couple of weeks. So again, that's tremendous progress. And again, can be due to a number of mitigation strategies. It's never just one. Again, we've had very strong vaccination efforts. There's strong education efforts, behavioral changes. We've had, identification of individuals at most risk so that we can target these interventions better. I think it's made a tremendous difference. So that's how we use epidemiology to again, gain the highest impact of our intervention. So let's go to the next slide, and we'll talk just a little bit about what this can relate to, what this means. So we collect data about our monkeypox cases and about their demography and about their exposures so that we know who best to target, what populations are at greatest risk. And very interestingly, in this outbreak, this has not changed throughout the entire outbreak since May. And, that's not always the case. As outbreaks evolve and as viruses evolve, and even in COVID, you saw differences in populations at risk over time. This has been very consistent. And I think it's allowed us, at least to date, to really be able to target this risk and make a huge difference. And as you saw that curve go down. So again, the vast majority of our cases, 98% are male. The vast majority identify as MSM. Our age range has been 4 to 68 years. Our median case age has been consistent throughout, in mid-30s or so. We've had a couple of several cases among young children that were household contacts of known monkeypox cases and were exposed in a kind of very close and prolonged exposure setting in a household. For our case patients in Georgia, close to 80% of them have been of Black race, the vast majority non-Hispanic, and the main risk factor reported has been close, sustained physical or sexual contact with someone who has had monkeypox. As far as kind of the severity of the cases here in Georgia, most of our cases have not been hospitalized. Only 5% have been. Although 60% or so of our cases are HIV positive, and about 42% of them have had a recent, within the last 12 months, sexually transmitted infection. So essentially, that information, since it's been so consistent, allows us to say, here is the population we need to target for vaccination, for early treatment, for behavioral education as well. And I wanted to go on to our next slide and talk just a little bit about this. This is new. And as we, again, as outbreaks evolve, we learn more over time. The vast majority of monkeypox infections, although they're of long duration, even up to 4 weeks long, have not been clinically very severe. And as I mentioned before, only 5% or so have been hospitalized. Here in the US, CDC sent out fairly recent, about a week or so ago, a recent health advisory. Again, speaking about that, we're starting to be able to characterize some severe monkeypox infections, not just mild, quote unquote, mild ones. There's really only been, a handful or so of cases, less than 10 or so. But although rare, severe manifestations can occur. Limited data about all of this. This is brand new. And there have been some real hallmarks in these severe cases that I think are a good reminder for us in public health and for our clinical partners as well. Most of these individuals have been HIV positive and have severe immune compromise. So again, they're not on antiretroviral therapy for whatever reason. And again, are considered to have severe immune compromise. They may present with an atypical rash that looks a lot different than the monkeypox rash that we've seen so many pictures of. They may, in fact, be really severe, like necrotic or coalescing, where it's not just some individual lesions, but they're really spread all together, all over the body. But one of the interesting hallmarks is that these individuals really have all shown the propensity for really rapid deterioration. So that if we were starting to suspect that an individual is immune compromised and is beginning to show some of the clinical instability or severe signs of sort of an atypical rash, they need to be treated immediately. They need to be watched very closely because it seems like in these reports the deterioration is like overnight. It goes from having this rash to having multiple organ involvement. Including, again, pulmonary, neurological manifestations, cardiac, ocular manifestations as well. So again, the treatment options, again, there's not a lot of data about this as well, but we're learning that, again, giving IV TPOXX as soon as possible is important, and even giving a vaccine immune globulin IV may be of benefit as well. There have been a couple of fatal cases here in the US. The official count is 2, although there are still a few under investigation. But I think for us all, as we're thinking about this, this shows you, again, how the epidemiology of what we're seeing, both by demographics, behavior, and also clinically now, really helps us target these individuals that may be experiencing severe cases. Meaning that if individuals are immune compromised or they have HIV, they should be prioritized for monkeypox vaccination. They should ensure as much as is possible for providers to get them back on antiretroviral therapy and ensure that individuals that are being evaluated for monkeypox are also tested for HIV if they have that as well. And so again, this will help us get a handle on so that these individuals may, may not progress from their severe infection to a fatal case. Next slide, please. So all in all, I think we'll learn much, much more about monkeypox as time goes on. I don't think monkeypox is over by any means either, and we continue to have the opportunity as we continue learning more about the epidemiology to prevent and mitigate both monkeypox and COVID and whatever comes next, and there'll likely be something that you'll hear me talk about in the months to come. So again, using this information really helps us target these both pre-exposure and post-exposure prophylaxis. And I hope that as our next presenter, my colleague, Dr. Millman, will be able to show you how we sort of take this information and translate it into prevention. So I'd like to thank you all so much for your kind attention. It's been a pleasure to be with you in person and virtually as well. Thanks so much.
Thank you, Dr. Drensick. We can save questions for you until after all of the presentations, I think. One thing, however, the acting secretary is fairly new and is yet to attain competence. What he was supposed to do was ask the board, who have all reviewed the minutes, whether there are any corrections that are needed. And so I'll do that in his absence.
Yes, this is Dr. Cheek. Can you hear me?
Yes.
Oh, good. Thank you. And I understand about being new to the job. Sometimes we all have those moments. So thank you very much. I was unable to attend the meeting last time, and so I was looking over the minutes, and I specifically just wanted to make a comment on Dr. Mercer's comments near the end. As we look at the strategic plan, which was a wonderful presentation from what I can tell, I do want to emphasize that I feel as the pediatrician, I'd be an error not to mention CMV again for children. I think she put it in there for maternal health, but going forward over the next 5 years, I certainly do wish that we would look at CMV as it is a #1 causer of hearing loss in our child's population. And so if we could detect this early, and there is some intervention for children with CMV. So I just would like to add my comment that I would love to see us take a look. I know we probably can't do universal screening, or that's probably not appropriate at this point in time, but some targeted screening on kids that fail their hearing screens, I think would be very appropriate. So if that would be my addition to the minutes, if possible.
Thank you, Dr. Cheek. I'm sure there's someone in the room who will add that to the minutes. And so, having heard that, is there a motion to approve the minutes? Mr. Walker motioned. How about a second? I'll second it. All in favor, say aye.
Aye.
The minutes are approved. Now we're going to hear from Dr. Millman. Thanks.
Okay, so thank you, everybody. So here today, I'm actually going to be talking in reverse order, starting with monkeypox, and going to be providing some updates on where things are right now with our monkeypox vaccination efforts in Georgia. So next slide, please. So just the overall picture of where we are right now with vaccine availability compared to where we were months ago is we're in a much better place. There's a lot more vaccine than there had been. We've been able to expand vaccination so that it's offered to more people than before. And we've also been able to continue to have vaccine be available throughout the state of Georgia, particularly through appointments that we have available in all of our health districts. So I've provided just information up here for people looking at the slides on the central scheduling system that you can use to schedule an appointment for vaccines at one of the health districts in Georgia. There's also a telephone number that can be called as well to make appointments there. So given the currently available supply, vaccine is still being prioritized for specific indications. However, those indications have broadened significantly since the outbreak first began as our vaccine supply has increased. Additionally, as cases have declined and more people have been vaccinated, vaccine demand has also begun to decline compared to earlier in the outbreak. So I just wanted to highlight that, and that we have more supply than we had in the past. But as Dr. Drinzik showed in her presentation, due to many of the efforts that we've had in terms of being able to get more people vaccinated, we are actually fortunately seeing a decline in cases as well as a decline in vaccinations as well, given that many of the people who needed to be vaccinated were able to get access to their vaccine. Next slide, please. So just wanted to highlight where we are right now with our vaccine administration data in Georgia. So as of October 5th, 2022, there were 25,639 first dose recipients that we've had, and we have vaccinated 15,728 second dose or gotten second doses to that many individuals. So we have been able to fully vaccinate a large share of individuals who had already received first doses. If you look at some of the demographic characteristics of the comparing the first and second dose recipients, you can see that the age groups are similar. Slightly less frequent male in first dose recipients or based on self-reported gender, but by and large, the vast majority are self-reported as male. We've been able to vaccinate a slightly larger number of Black or African American first dose recipients compared to second dose recipients. Part of that was also due to many of the successful efforts that we had around Labor Day weekend with our efforts to vaccinate people for Atlanta Black Pride, which was part of a health equity initiative where we were able to get almost 4,000 individuals vaccinated during that time. And the majority of individuals too have also been non-Hispanic. These data are available on a weekly basis and they're updated every Wednesday. Next slide, please. So in terms of our vaccine priorities, the unchanged priorities that we had that we've really been emphasizing since the beginning of the outbreak of monkeypox has been trying to get vaccination for people for post-exposure prophylaxis as well as expanded post-exposure prophylaxis. So essentially, these are individuals who either had a known exposure to someone with monkeypox or were very likely to have had an exposure to somebody with monkeypox and needed to be able to get vaccine within that 14-day window, so that the individual would be able to hopefully prevent a case from occurring as a result of that exposure. But if we go to the next slide, one thing that has actually changed is we're now actually at a place, given the increased available supply that we have, as well as the declining demand that we have for post-exposure prophylaxis and expanded post-exposure prophylaxis, we are now able to start offering vaccination to more individuals as pre-exposure prophylaxis. So the main difference here is pre-exposure prophylaxis is this is vaccination for people before they have had an exposure to monkeypox. For people with, and it's right now, it is still not for the general population. It is still limited to certain individuals based on occupational or sexual exposure risk factors that may make them likely to have an exposure to monkeypox at some point in the near future. PrEP for monkeypox vaccine is also indicated for sexual partners of those who meet the eligibility criteria to be vaccinated for pre-exposure prophylaxis, as well as for people who may not currently have one of the risks for getting for being exposed to monkeypox, but for people who anticipate potentially having one of those risks at some point in the near future. So this is really going to be able to broaden the access to monkeypox vaccine for a much larger group of individuals, and hopefully be able to continue to keep our numbers down and to be able to help us contain and control the outbreak. Next slide, please. So one thing that I wanted to be able to highlight earlier on in the outbreak, we were giving this vaccination based on data that we had from other outbreaks, as well as from laboratory studies. We had strong suspicion that this vaccine would be able to protect people from infections. But now we have data that are actually showing what some of those effects are. So this is a recent CDC MMWR that came out that really, I think, is highlighting that monkeypox vaccine is offering protection from infections. So this is looking at data from 32 different jurisdictions in men between the ages of 18 and 49 who received at least one dose of the monkeypox vaccination. And I think that this is what it really highlights right now is that this vaccination is truly able to protect people who have had an exposure from being able to develop monkeypox. So what you can see here is that people who are unvaccinated, the incidence of monkeypox in people who are unvaccinated was 14 times as high compared to individuals who had received at least one dose 2 weeks prior. So we can see that even one dose of this vaccination is able to offer substantial protection to people who have had an exposure. We still have questions. We don't necessarily know how long the duration of that protection is going to be. So it's really, really important that people do get the second dose so that they are able to get the best protection for the longest period of time. But I just wanted to highlight that these data are very useful in terms of just being able to show that this vaccine is highly effective in preventing cases. And it really does also support the use of the vaccination to try to control this outbreak. Next slide, please. One thing that I also wanted to be able to highlight too is that one of the issues that has come that has become to light as we have done more intradermal administration of the vaccine is that people who have received it do have more frequent local skin reactions around the site of the intradermal vaccine. The site that had been used was similar to what was being done for TB testing. So it was the inner surface of the forearm, also known as the volar forearm. This is something that people have continued to have, or some people continued to have, discontinued discoloration of the skin, sometimes weeks to months after they had received the vaccination. While it is something that has been described, and it is something that does improve with time, it is also in a visible area. It is also in a visible area of the body. So one of the things that we are very happy about is that in an effort to be able to continue to offer this vaccination to individuals, so people are able to get the protection that they have, we are actually also now able to do intradermal administration of monkeypox vaccination in other locations outside of the inner forearm, particularly on the upper arm around the deltoid, where people would get most other intramuscular injections, such as your flu vaccination, as well as in the upper back below the scapula. So that this really does allow people to be able to have alternative sites that they can use for vaccination. And I think that it's something that the protection that one is able to get from these alternative sites should be the same as from getting it intradermally in the forearm. But this really does just open up the possibility for more people to get vaccinated, particularly if there may have been hesitation that people were having with getting their second dose because of the skin reaction that they had in a visible location. So this is something now that if people are coming in for their first or their second dose, they can ask their providers about getting vaccination intradermally in an alternative location if that's their preference. Next slide, please. So I just wanted to now highlight some of our ongoing vaccination efforts. So as I had mentioned, we've broadened vaccine eligibility criteria to increase access to populations that may have higher likelihood of exposure to monkeypox. We are continuing to work with our local health departments and our community-based organizations to try to increase the uptake of both first and second doses for eligible populations. The partnerships that we've had with our local health departments as well as with the community-based organizations have really been essential to the success that we've had in terms of getting vaccination out to the populations that need it. So we are very thankful for the partnerships that we've had, and we're very happy that we can continue working with them to try to get more individuals who need it vaccinated. Finally, even though the outbreak appears to be improving at this time, we continue to work with our colleagues in terms of examining what's happening with the outbreak epidemiology, so that if there is a need to reevaluate any of the vaccination priorities, and we would be able to do so in the context of the currently available vaccine supply. Next slide, please. Okay, so now I'm going to shift gears a little bit to talk about COVID-19 vaccine. Next slide. So the big update for COVID-19 vaccinations is about the bivalent booster. So bivalent boosters are updated COVID-19 vaccines that protect against both the original strain of the virus as well as the Omicron BA4, BA5 variants. So the thought is that because these vaccinations are able to protect against both of these, we're going to be able to have better protection, particularly against some of the circulating Omicron variants that seem to be able to evade or that seem to have better immune evasion for people who had the original vaccine virus. Vaccine. So this is something that is going to hopefully be able to provide broader protection for the general population that receives it. So since August 31st, bivalent formulations of the Pfizer, which is for populations 12 and older, and the Moderna, which is for populations 18 and older, COVID-19 vaccines have been authorized as a single booster dose at least 2 months after completion of the primary series. And this is primary series of any COVID vaccination series that one has received, not just individuals who had received mRNA primary series. Additionally, for people who had received a monovalent booster, the bivalent booster is then going to be administered to that individual at least 2 months after the last monovalent booster. At this time, the bivalent booster is the only booster that can be used in populations 12 and older for Pfizer and 18 and older for Moderna. I also just want to highlight as well that the bivalent booster can be co-administered with influenza vaccinations. So now is really a great time to be able to get vaccinated for COVID and for influenza if you have not done so already. Next slide. So wanted to just highlight a little bit about where things stand with the bivalent boosters right now. So as of 3 p.m. on October 6th, this provides the breakdown of what we have for bivalent booster doses that have been administered in Georgia. So for the Pfizer bivalent doses that have been administered, we've had around 179,000. Doses in total. The majority of the recipients of that have been in the 18 to 64 year age group. For the Moderna bivalent doses, we've had fewer, 95,000 in total, and the majority of those have been in the 65 plus age category. Next slide, please. So just on the horizon, and I was also checking right before this meeting because we think that this is going to be pretty imminent. But Pfizer and Moderna have submitted data to FDA for pediatric bivalent boosters. But there's been a pre-order period for the Pfizer vaccination as well as for the Moderna pediatric bivalent boosters that has already ended. And what will happen is, as with some of these other vaccinations that have happened with the pre-order periods, once FDA has authorized use, providers that had pre-ordered will have their vaccine pre-orders shipped to them, and then regular ordering periods for vaccinations will open up for other providers who had not placed pre-orders. We anticipate that the FDA will be deciding on this pediatric bivalent authorization very soon. So this is something that is likely going to be getting rolled out very, very soon, although I don't have an exact date that I can give you right now. All right, so thank you all for your attention. I'm happy to take questions at the end. Is what it sounds like the preferences.
I think we could take questions for Dr. Millman and Dr. Drensick on infectious diseases now, and then to the opioid one after that. Are there any comments, Dr. Toomey?
No, I have something that I asked you last week, and I don't know if there's any new answers. You know, the bivalent booster works primarily against not only just COVID, but Omicron 4 or 5. Do we have any sense at all how it's going to protect us against these new emerging Omicron variants? Because I think that's the questions I'm getting from the public. Is this going to help us as the variants change? And we may not know, but it's kind of, I'd love to hear you speculate.
All right, so we don't know exactly what the protection is going to be from those new variants. What we do know, though, is that even when we had the monovalent booster that was being used, and even though the protection that one may have had from infection may have,
do you think that's a blueberry grape?
Is that better? Okay, so what I was saying is for people who we don't necessarily know what the protection is going to be against those new variants. What we do know is that for the monovalent booster, even though the protection against infection seemed to be reduced against some of the variants like the Omicron variant compared to what it had been against the original strain of the virus, we do know that the protection that individuals had from the severe outcomes such as hospitalization and death continued to be very high. So while I can't say what the actual protection from infection with these new variants is going to be, I do anticipate that being able to get that immune boost for people, even for people who have previously been infected with COVID, will be able to offer additional protection for individuals, particularly against some of the most severe outcomes, such as hospitalization and death.
I heard on a radio program that there's a doctor in Tampa Bay, Florida, I think, that is saying the mRNA technology was causing damage to males 5 to 39 years old. Have you guys heard anything about that? And, you know, I'm wondering if there's any real evidence out there to refute or corroborate that. Have you heard anything about that?
So I can't speak to the to the specific situation that you're mentioning with this individual, but at least in terms of the mRNA COVID vaccinations that have been done, these vaccinations have been studied for safety effects extensively, and the original clinical trials that authorized them. And there's continuing safety monitoring that's happened after the vaccinations have been authorized. There's data reporting that happens through a variety of mechanisms. So one of them, for example, is VAERS, which is a CDC reporting mechanism. COVID vaccination has also had VSafe as well as another way for people to be able to report report adverse events. And in terms of any vaccination that happens, there are people who are going to have adverse events that happen. And the question then becomes, is this something that's related to the vaccination, or is this something that is not related to the vaccination? And by having people report issues that they have after receiving vaccine, it allows people to be able to look at those data to be able to try to determine, does this seem as if it could be related to a vaccination or not? So for example, through these safety monitoring programs that we've had, one of the things that happened with the mRNA COVID vaccination is we were able to detect signals related to risk for myocarditis or the heart inflammation that individuals have been able to have. Similarly, for other issues, been able to identify the risk of blood clots that have happened. So these systems are able to evaluate what's happening with people who have received these vaccines over time, so that if there are issues that arise, we can try to identify what those are, and if recommendations do need to be modified, they can be as a result of having those data.
How does the vaccine know that it's a male or a female and cause these problems? Is it something in the makeup or something?
So specifically for the myocarditis related to mRNA COVID vaccine, so it as you mentioned, as you said, the people who are at highest risk for getting myocarditis after mRNA COVID vaccination are young men. And this is something that has been that has been described and detected through those safety systems. Why exactly it affects that population more, I don't think we necessarily have a complete answer that I don't have a complete answer that I can give you as to sort of why is there sort of a higher frequency of this happening in younger men. However, what's also been seen is that COVID infection itself has a very high risk of also causing myocarditis in individuals. In fact, the risk of myocarditis in young men who have COVID infection is considerably higher than the risk of myocarditis in individuals who have received the mRNA COVID vaccination alone. So based on that the benefit of getting the COVID vaccination, even for that population, continues to be higher than the risk of foregoing the vaccination. And for people who are in some of these populations where they may be at risk for having myocarditis, if that is a concern, it's important that those individuals have that discussion with their physician in terms of the vaccination, learn a little bit more about what the issues are for them and what they might consider and what symptoms they need to look out for. And they can also speak to their physician too about if there's an alternative COVID vaccination that may be more acceptable for that individual.
Thank you, Mr. Walker. Any other comments from the board? I have some. I think that we are really fortunate in the state of Georgia and fortunate here in the Board of Health to have Dr. Drensick and Dr. Millman doing their job and being so open and transparent about it. I just want to highlight a few things. First of all, the importance of information and surveillance and then following that data in practice and targeting. With COVID, we've been blessed, I think, to have Dr. Drenzik not always tell us everything's great, it's going to be better, but tell us what she knows and what the truth is. And one thing we've learned about the COVID pandemic is that everything changes and that they have to be cautious about overinterpreting or saying it's all over too soon. So she's not being negative, she's just appropriately being cautious about this. Then I want to talk about monkeypox a little bit too, and vaccine safety. First of all, vaccine safety. Dr. Millman laid it right out there. When you're comparing safety of vaccines, there are three comparison groups. The mRNA vaccine compared to the other vaccine, which is associated with blood clots. So there's some complications with both of them, and they're compared to people who haven't gotten the vaccine. The other important comparison group is people who haven't gotten the vaccine who get COVID. And in every case, COVID causes more of the complications than the vaccines do. Now, that could be a clue as to what causes the disease. For example, you might speculate that the mRNA vaccine is an immunogen and that myocarditis is an immune response to the virus, and perhaps an immune response less frequently to the vaccine. So if you were absolutely sure you were never going to get COVID, it'd be one thing, but almost everybody gets COVID. So the vaccine is far preferable to the virus. The important thing about vaccine safety is transparency, and that's what Dr. Millman's doing. There's a whole group of people out there that are anti-vaxxers, and they're dangerous people from my point of view. I'm pro-vaccines. They're even sometimes politically connected, which makes it even more dangerous because they influence certain politicians to take their side. It's very important to be transparent, not overemphasize something, put all the data out there and then explain it. That's why we're so fortunate to have these people here with us. Third thing I wanted to say is about monkeypox. This is sort of my area. You can do it. It's very confusing to people that all vaccines aren't the same and all diseases aren't the same. So we've been encouraging everybody to get COVID vaccines. Now we're encouraging this to be highly targeted. So when you say something's targeted, it's not just because there are scarce resources. It's also because that's the most effective way to reduce the epidemic. You need to put the vaccine where the problem is. And with a virus like monkeypox, that can be really effective if you target it. It's a little like smallpox, really. You're ring vaccinating around the cases and the highest risk people, and that can cause things to go down. They've gone down because the CDC in Georgia have been very effective in targeting what was initially scarce resources to other resources. It's extremely important. The other thing was working with communities who are most highly affected. In this case, the most highly affected community in Georgia are Black men who have sex with men, but all men who have sex with men, and a lot of them who have HIV, which makes them very susceptible to serious illness. By working with those communities, going to Black Pride weeks, you're telling people, we're with you, we'll get to give you the vaccine, but also this is what you need to know. And one really encouraging thing came of a study that was actually led by some folks from Emory, but included Georgia and other states to show that the sexually active gay community has decreased their number of sexual partners in response to monkeypox by more than 50%. In other words, good communication, good working with community, good targeting can bring this down in a combination of ways. And it's not just the vaccine, it's not just the education, it's not just working with communities, it's all of those together. And we need to give a round of applause to our people here in Georgia. Sorry for going on too long. Amy, it's up to you now to bring us home. Amy Benson. Yeah.
Hi. Thank you for having me today. I want to say thanks to Dr. Toomey, the leadership team, and the board for having me present on this topic today. I'm Amy Benson. I oversee the Opioid and Substance Misuse Response Program here at DPH, and I've been asked to talk today about rainbow fentanyl. Next slide. So rainbow fentanyl is a nickname that's been given to an emerging drug trend of fentanyl that is produced in various colors and forms. So you can see some pictures here of the colorful pills and the chalk-like substances on the slide. So rainbow fentanyl has been getting national media attention after the DEA issued a press release in late August to warn the public of this new drug trend and the recent seizures that they've had. So the report stated DEA and law enforcement partners seized this brightly colored fentanyl in 18 states. A recent seizure in New York found 15,000 colored pills hiding in children's toys, likely a tactic to disguise, but still concerning. And there are also evidence that appears to market the substances as party drugs. As confirmed by our partners with the Atlanta Carolinas HIDA, the high intensity drug trafficking area, it is important to note there have been no seizures or reports of the brightly mixed colors of fentanyl in Georgia or our bordering states at this time. Only purple substances have been seen, although we do recognize it is likely only a matter of time, given typical drug trafficking patterns that we see this in Georgia or nearby. Next slide. So what is rainbow fentanyl? Number one, it's a substance, why, misstated that. Why is rainbow fentanyl a concern? Number one, it's concerning because of course fentanyl is extremely deadly. And number two, colorful items appeal to young people. So although using colors to appeal to young people has long been a tactic used, for example, by tobacco or alcohol, there appears to be no evidence at this time that drug dealers are specifically targeting youth with this substance. Drug policy experts argue young people are not the intended audience for these substances due to associated risks and business practices. But regardless, I think the key takeaway here is to further awareness that fentanyl is extremely dangerous and deadly and is out on the streets in many different forms, including pills or powders in a variety of colors, shapes, and sizes. The picture on this slide is from the Cobb County Sheriff's Office of a purple substance that was seen by the Marietta Cobb Smyrna Organized Crime Task Force. So that's an example of the purple that's been seen here in Georgia. Further facts and reminders about fentanyl. It's a very potent synthetic opioid. It's hidden in street drugs. It cannot be detected by smell, sight, or taste. It is illegally obtained. Any illegally obtained drugs has a high potential to contain fentanyl, and it is often made to look like prescription drugs, making it very difficult to determine if it's legitimate or fake. Next slide. Okay, so drug overdose deaths continue to increase in Georgia. I think most of us here know that. The latest drug overdose death data from our drug surveillance unit here at DPH shows the number of overdose deaths by drug type between 2019 and 2021. That's what this chart is showing here. Amphetamine and cocaine-involved overdose deaths started to increase throughout the pandemic after slightly leveling off in previous years, but have not increased as greatly as fentanyl and other opioid-involved deaths. Fentanyl continues to drive the increases in overdose deaths both in Georgia and nationwide. Next slide. Okay, this chart shows fentanyl overdose deaths in Georgia by quarter during that same time period, 2019 to 2021. And this is showing an increase of 230.6%. Next slide. The Drug Surveillance Unit recently released a report on overdose deaths among adolescents in Georgia that shared some alarming trends. From 2019 to 2021, overdose deaths among adolescents, those ages 10 to 19 years, increased 142%. In 2021, overdose deaths among adolescents increased 70% on its own. And fentanyl-involved overdose deaths increased at a faster rate among adolescents than adults. Next slide. This chart breaks down deaths among adolescents by type, number, and rate between that same time period, 2019 to 2021. As shown in the bolded red, fentanyl-related overdose deaths among youth ages 10 to 19 increased by 800% during this time period. Next slide. And then this graphic is showing overdose deaths by residents in Georgia during the same time period. We see there are some higher numbers in more populated areas. However, I want to point out there are many rural counties that are also being affected by this. Next slide. Okay, so what are we doing about it? I like to think we're doing a lot, but I want to run through some of the current efforts that our program is working on. The first is we currently fund a position in all the 18 health districts called our Opioid Public Health Analysts. We call them PHAs for short. They provide local level support to surveillance, prevention, and response efforts. So I encourage everyone to get to know your local PHA in your district if you don't already, and we'll be happy to provide that introduction. They're doing some wonderful work. We also work very closely with the Drug Surveillance Unit, as I've already mentioned, but them in combination with our PHAs, we used data to detect potential outbreaks and clusters of overdose and coordinate response to inform our partners. That's a key piece of what our program does to try to mitigate the issue. The third bullet point here, speaking of our partners, of course, we cannot accomplish anything without them. Much of this coordination and collaboration is done through the Georgia Multi-Stakeholder Opioid and Substance Use Response Plan. We're in the works, or a new plan is in the works, hoping to publish that soon, and is a partnership with the Georgia Department of Behavioral Health and Developmental Disabilities and the Office of the Attorney General. We recently launched our Stop Overdose Awareness campaign to bring awareness to the dangers of fentanyl and polysubstance use, which is the norm, and the importance of naloxone. Provided an example of one of those images on this slide. The campaign utilizes various media platforms to educate Georgia citizens on the overdose crisis. The Drug Surveillance Unit has implemented a Georgia Public Health Laboratory toxicology testing pilot program to provide rapid identification of fentanyl and fentanyl analogs involved in non-fatal drug overdoses. So at this time, 23 emergency departments have been onboarded to participate in the program. And this program fills an important gap here in Georgia, as it has historically been very difficult to test for the presence of fentanyl in non-fatal drug overdoses. So we're excited to see what happens with that pilot. And then lastly, we are working creatively to increase access to naloxone and fentanyl test strips, working with our partners and our PHAs, as I mentioned. So that's just scratching the surface, but wanted to provide a few of those highlights of our program. So next slide. Okay, so I want to share how you can help. So as far as preventing teens and young adult substance use and drug overdose, it's important to encourage parents and caregivers to talk to their children about substance use. I know that's a difficult thing to do, but the research has shown that parents have a very significant influence in their children's decision to experiment with drugs. So I think that is so important, and there's a lot of resources out there that can help get that conversation started. It's also would be great to get involved with prevention efforts in your local community. For example, connecting with your local PHA, getting involved in a local drug task force or a coalition. It's important to recognize the signs of youth who may be at risk for drug use. And you can see some of those signs on the screen there. And then provide opportunities to educate and bring awareness to youth about the risks of hidden fentanyl and illicit drugs. Next slide. Okay, so how you can help individuals who may use drugs or are at risk of experiencing a drug overdose. Always good to be prepared. Know what naloxone is, carry it if you can, be prepared to administer it to someone that you know, if you know someone that could be at risk. That's very important, can help save a life. Know how to refer someone to help. Georgia has the Georgia Crisis and Access Line available 24/7 for access to services and immediate crisis help. So if you're ever unsure of what to say to somebody that says, how can I get help? You know, I recognize I have a problem, or I have a family or a friend that needs help. That's a great place to start. And then increase awareness and educate others on the risks, which hopefully I've done today, associated with drug use, signs of an overdose, and how to respond. Okay, so thank you so much for allowing me to come and speak today. I'm happy to answer any further questions. My information is on the screen. Thank you.
Any questions or comments from Ms. Benson? Amy, that was excellent. It was scary as hell. I mean, when you add that information in with the increase in suicides in youth, and the overall increase in drug overdose deaths, and how small this is. I mean, just to think about 10 grains of salt on a marijuana cigarette killing you, for example, is, it's unbelievable. The test strips really work if they're used right, I guess, and they're even more sensitive than you think, but they have to be used at the right time by the right people. Thank you so much for what you're doing. It's just scary to me, really scary.
This is Dr. Cheek again. Where does the public get test strips?
That's a good question. Currently, I would recommend our harm reduction partners and organizations are throughout the state. They're the ones that have those on hand. I can't make any promises on that they will, but they're the organizations to get in touch with. We do have a harm reduction work group as a part of our strategic plan, so I'd be happy to help connect to those resources. We are working on some pilots within our program to be able to get fentanyl test strips out to the general public or to those that need it through some of our CDC funds now that it's an allowable expense under our grant. So I hope that we'll have them more readily available and would like to see that happen through our district PHAs locally.
Are there harm reduction partners listed on the department's website?
I am not sure, but I would be happy
it could be done, right?
Yes, yeah, that's a great idea.
Dr. Toomey.
May wonder why did we do this today? Because we have not yet had evidence of this in Georgia, and it's precisely for that reason, is to raise awareness. And also with Halloween coming up, that this is something that potentially could be a problem if individuals who are malicious could use that as an opportunity to give to children in their candy. I mean, it happens, and it's happened elsewhere. And it's just to raise awareness, but not to alarm the public, that this is something that is being seen elsewhere. So it's being proactive, preemptive strike.
It's also important for parents to know about harm reduction because, an adolescent addict, for example, may not actually be going to the Department of Public Health website. They might, but they might not. But parents can, and certainly doctors, pediatricians, family doctors, practitioners should know as much about this as possible. Any other comments from Ms. Benson? Thank you so much.
Thank you for a good presentation. This is Dr. Cheek. I just had another question, I guess, before we getting close to leave. I was just looking on the CDC website because we have been so overwhelmed in my community with flu, especially our outpatient departments and outpatient EDs. And I saw that we were #1 in the country for flu. And I just wanted to ask a couple of questions. We are experiencing a shortage of the antivirals, especially in the solutions. Very hard for families to find if the practitioner wants to provide that or the family wants that. And also, I would just wondered if anybody has any comment on vaccine in terms of uptake, and also about whether or not the strains that we're seeing now are in the vaccine, and how is the match for this year? I haven't really heard that. So I know this is a very learned panel and y'all probably know all those answers. So I just wanted to ask that before we ended the meeting, if that was appropriate.
Hey, Dr. Cheek, this is Sherry. I'll start. I can answer a few of those questions. And I'll ask Dr. Millman or others to help with some other things as well. It's really interesting. We really are seeing quite a bit of flu. And we're really just at the beginning of the flu season. We're really kind of ending one and beginning the other, sort of technically, although we've seen flu activity for a few weeks now at pretty high levels. And again, we really our flu surveillance, as you may recall, is really just an opportunity to put together a variety of pieces of the puzzle where we look at outpatient illness with influenza-like illness, where we look at hospitalizations due to flu, where we look at flu outbreaks, and where we look at also what viruses are circulating in communities and in states as well. So for some of this, we really are just starting to get a picture. This so far this year or this season of the few weeks old that it is, we're certainly seeing a predominance of influenza A. And for the ones that are subtyped, they're influenza A H3N2. This is similar to really what we saw last year, although again was, the activity was much lower. So we don't know for certain yet this early in the season exactly what the match will be in regards to the flu shot. It's because it's really just starting. However, realize that as is true of every season, the flu vaccine contains, 4 variants of flu, 2 influenza A, 2 influenza B, based on viruses that were circulating last year and based on information from the Southern Hemisphere. So again, we're hoping that no matter what, even if the match isn't perfect, we certainly do see reduction in infection, duration, clinical severity, hospitalizations, and deaths from flu. So it's really important, even early on, if we don't know the exact match, that the flu vaccine, again, be promoted very, very strongly, especially with this early, sort of high activities in flu as well. So I think other than that, I think that as far as this season's exact uptake, I don't have the data in front of me about flu vaccine uptake, although again, I'm not even sure, Alex, do you have that? We can send that out, Dr. Cheek, if we don't have it with us. But again, a lot of this is really, has just been starting over the few weeks. But predominantly, when I look at a lot of our influenza-like illness outpatient data, we're seeing a lot of flu in young children and school-age children as well. And we've documented a few influenza outbreaks in school settings and also in long-term care facility settings. So again, much of, again, as we mentioned earlier in these presentations, sort of knowing the population at risk is really important, because H3N2 years very often preferentially impact elderly and also young kids as well. So, but I'll stick to the most important line that we'll hear today. Everyone over the age of 6 months should get a flu vaccine this year and every year. So.
Dr. Millman, do you have anything to add?
Sure. So just to supplement a little bit on what Sherry had mentioned, the flu season is one of those things where you never know exactly when it's going to when disease uptake is going to start, but definitely we're seeing an increase in it in Georgia. So now is definitely the time for people who have not been vaccinated to get vaccinated. As sort of is the case that we hear with other vaccines, you don't really get your maximum level of protection until about 2 weeks after you've been vaccinated. So for Georgians who have not been vaccinated, please do get vaccinated now. Just looking at the levels of activity that we're seeing here locally. CDC will provide information on just interim seasonal vaccine effectiveness data, but that doesn't come out until much later in the season. We have to just remember that, October is usually when most people are starting to get their flu vaccine. So any coverage that we're going to be seeing for a lot of people is probably just going to be low, since people are getting their vaccines as we're speaking right now. But we definitely, what we can say is that even in times when there's not a perfect match with what the strains are in the flu vaccine. Any additional protection that one is able to get is better than no additional protection that they're able to get, particularly for people who are with certain chronic medical conditions or older adults in particular who are at most risk for severe disease. It's really, really important to be able to get that additional protection because that can truly make the difference between somebody being hospitalized or dying or not. In terms of the question about the antiviral situation, so CDC does put out information on their website just about antiviral drug supply. I'm looking at it right now. They do say that there's currently no major market shortages of the antiviral drugs for treatment that are being reported right now. Although that doesn't necessarily mean that in some local areas there might not be challenges in terms of being able to get certain medications. There's a website that they do mention called that's www.medfinder.org that can be used that may be able to also help identifying pharmacies that may be able to indicate where certain antiviral drugs are in stock. And just one thing to also note, just because you did specifically mention the liquid formulation. So when the commercially manufactured liquid suspension formulation is not readily available, it may be possible that pharmacists can compound an oral suspension from oseltamivir 75 milligrams capsules as an alternative. So if truly it can't be found, that may be something that could be seen as an alternative for people who may need it.
Thank you, Dr. Drensick, Dr. Millman, Dr. Cheek. Thank you for bringing that up. That's terrific. Any other comments or questions? Dr.
One thing I neglected to mention to the board is that this is we are now sitting in the building where we will be moving in a few months. And the audio visual and just the access here is so much better than in our old building, that we will likely continue to have our meetings here. And I think it'll get easier to access now that you know where to park and those things. But I'm sure that you will find it a much better place for lunch. There's actually a cafeteria. We can meet down there for lunch prior to the board meeting. And so there's just a lot more amenities here than there were, particularly now at 2 Peachtree. But that building is slowly being emptied, and virtually everybody in that building are moving either here to the Twin Towers or one of the other buildings here on Capitol Hill. So I just wanted to let you all know. This is a preview of coming attractions.
This is my first meeting in this building. It's terrific. Mr. Walker, the newest member of the board, has the most seniority for meetings in this building. He's been to both of them. That's it.
That's a good thing or a bad thing, but it's true.
Shows enthusiasm. Are there any other comments anybody else wants to make about anything? And I can remind us that the next board meeting will be on November 8th in this building. It'd be virtual, but the people from the department will be in this building. So thanks to everybody. Goodbye.